Hello everyone. So today we will be discussing the most important topic, endometriosis. Endometriosis is favorite of all the examiners, है ना? तो जल्दी से शुरू करते हैं. Okay? तो सबसे पहले I would like to tell you definition. Endometriosis होता क्या है? जब एंडोमेट्रियम टॉपिक साइट्स पे चली जाती है उसको हम बोलते हैं एंडोमेट्रियोसिस. ओके, एंडोमेट्रियल कैविटी में तो है ही है, के अलावा वहाँ से वो और साइट्स पे भी चली जाती है. एंड दीज साइट्स बी अदर देन यूट्रस, बिकॉज अगर ये एंडोमेट्रियम मायोमेट्रियम में गई देन वी विल से इट एडिनोमायोसिस, राइट. बट हमने तो एंडोमेट्रियोसिस हम कब कहेंगे? एंडोमेट्रियोसिस हम कहेंगे इफ इट इज गोइंग एट साइट्स, at ectopic sites other than the uterus. Okay? It should go out of the uterus. Okay, so what is basically the pathology behind it, and ये कैसे गई and किस में जाएगी? What is it? So the most accepted theory is given by Sampson. Okay, and it's also known as Sampson theory. Sampson said कि retrograde menstrual flow है ना, usually menstrual flow is usually menstrual flow is from the endometrial cavity to the cervix to the vagina and then out. Okay, but retrograde menstrual flow going backward from the uterus to the fallopian tubes and then to the peritoneal cavity or ovaries. This retrograde backward direction flow is responsible in a female who is having increased estrogenicity and immunodeficiency. इंक्रीज ईस्ट्रोजन होगा तभी तो एंडोमेट्रियम ज़्यादा प्रोलिफरेट करेगा. इम्यूनो डेफिशिएंसी होगा तभी जो है वो एंडोमेट्रियम जो रिट्रोग्रेड मेंस्ट्रुअल फ्लो से गई उसको बॉडी रिमूव नहीं कर पाएगी. ठीक है, so that is it, and this retrograde menstrual flow theory is known as the Sampson theory. अब क्या होता है जब ये एक्टोपिक साइट्स पे चली जाती है? when it goes to the ectopic sites, okay, then this endometrium, it undergoes the same hormonal changes which the endometrial cavity endometrium is undergoing, है ना? The and what hormonal changes it is going? In the starting 14 days of the cycle, this ectopic endometrium will also undergo proliferation. In the last 14 days of the cycle, it will undergo three changes, and then at last this endometrium will shed and bleeding will occur. Now यूजली तो एंडोमेट्रियल कैविटी से शेडिंग होके जो ब्लीडिंग है वो बाहर आ जाती है. बट यहाँ कैसे बाहर आएगी, है ना? यहाँ कैसे बाहर आएगी? इट नॉट कम आउटसाइड. पेरिटोनियल कैविटी और द ओवरी, द मोस्ट कॉमन साइट्स, दे आर द क्लोज स्पेसेस, राइट. so now these the blood will accumulate there only, the blood will accumulate there only, and this will start the inflammatory response at that site. Soon this inflammation will become chronic inflammation, क्योंकि ये तो हर महीने होना है ना? This has to happen every month. Okay, so this will lead to chronic inflammation, and all of you know that after chronic inflammation there is fibrosis and adhesion, which will lead to distortion of the anatomy of the genital tract. Okay, so basically in the peritoneal cavity there will be lots and lots of adhesions, and there will be distortion of the anatomy all over. Okay, now let's discuss the two types of endometriosis. The most common site as is expected, कि हमने बोला कि रिट्रोग्रेड मेंस्ट्रुअल फ्लो से ये चली जाती है, तो फॉलोपियन ट्यूब डायरेक्ट कम्युनिकेशन में है ओवरी के, तो सबसे ज़्यादा ये ओवरी पे ही जाएगी, है ना? द मोस्ट कॉमन साइट ऑफ द एंडोमेट्रियोसिस इज ओवरी, है ना? जब एंडोमेट्रियम इज गोइंग इन द ओवरी, now this endometrium will undergo all the hormonal changes, and after when the shedding of endometrium will take place, a lot of blood will get accumulated, as ovary is very small and a closed space. Now this time beta, this blood will get accumulate, and most of the time the accumulated blood is when we are doing laparoscopy, or when we are assessing, when we are treating it, we're doing the surgery for it, it is seen as a chocolate colored fluid, and that is why it is known as the chocolate cyst. Okay, now ovary, due to the accumulation of the blood, has a cyst in it, and because there is lot of blood has got accumulated, this blood will become chocolate color, and this cyst will known as the chocolate cyst. Okay, now when we will clinically examine this patient will have a adnexal mass. Okay, we will feel the adnexal mass, in which side there it is the chocolate cyst. Okay, uterus will be of the normal size. Okay, note should be made, a uterus will be of the normal size. Okay, and what is the investigation of choice? You all know that investigation of choice for any cystic structure is ultrasound. And an ultrasound, what is there in that cyst? There is lot of blood accumulated, so there will be homogeneous internal echoes. There will be homogeneous, equally spreaded internal echoes due to the blood, right? Internal echoes, which will give us the appearance of the ground glass appearance, just like these echoes will be like this, homogeneous internal echoes. Okay, so here I would like to know you here I would like to tell you here I would like to tell you that my Telegram channel is @TRRANA. Okay, and here we are practicing lot of PYQs and lot of images we are practicing daily. Okay, so you can join it, it's free of cost, and you can also become an excellent master of obs and gynae. Okay, it is a routine procedure we are following, so you can too join us. Okay, okay, so now clinical presentation, we will have a ground glass appearance. So now what will be the clinical presentation of this patient? Because this patient is having a very inflammatory ovary, so this patient will have a pain, secondary dysmenorrhea. Okay, it will be a congestive pain, secondary dysmenorrhea, and there will be a chronic pelvic pain, because that chocolate cyst is being there from a quite long time, right? And chronic pelvic pain and infertility. Okay, there will be chronic pelvic pain, and why there will be infertility? Because now ovary is full of inflammation, and ovary is full of inflammation, and the genetic material, the ovum which is there, is now raised in a very toxic environment, so the genetic quality will be totally lost, so there will be infertility and secondary dysmenorrhea. Please mind it, there is no dyspareunia. Till now, I haven't told you dyspareunia. Adnexal mass will never give rise to dyspareunia. Okay. Okay. Next is treatment. What is the treatment of this? Now, here I would like to tell you, for the starting of treatment, we can give NSAIDs, but usually these ovarian cysts, first of all, we are doing the treatment for the pain. I told you there are main two symptoms, pain and infertility. So, what is the treatment for the pain for this ovarian endometrioma? It is usually we give NSAIDs, but the patient, they don't respond to it, and then we have to do the cystectomy. Okay, so what is the rule for the cystectomy? Because we know that this lady is having a toxic environment in the ovary due to this ovary chocolate cyst, due to this endometrioma. So we would like to remove it if it is more than 5 centimeter. Even if it is asymptomatic, we would like to remove it, and if it is symptomatic, we would like to remove it earliest. Okay, so it is is cystectomy is done for the cyst more than 5 centimeter, or it is not and, okay, it is or symptomatic. So we have to remove this cyst. This is an endometriosis cyst. We cannot tolerate it much more. It is creating a very toxic environment in the ovary. The body is having a poor genetic quality of ovum. So we will do the cystectomy for any cyst which is more than 5 centimeter, or if the cyst is symptomatic. Okay, and you should know that all the medical management which we do in the peritoneal endometriosis, this ovarian cyst will not respond to that. Okay, we have only two options for the chocolate cyst. Number one is the SAT, and the another option is the cystectomy. Okay, you are not going to drain the cyst. IND नहीं करना है, aspiration नहीं करना है. Okay, the questions are repeatedly asked on your exam on these things. Okay, so you are not going to do the IND, or you are not going to give GnRH because they don't respond to it, and with IND reoccurrence occur much more. And for the infertility treatment, I would like to tell you that it will be same as peritoneal endometriosis, and which is here. Okay, so regarding the peritoneal endometriosis, I would like to tell you the second most common site of the endometriosis is pouch of Douglas. Whether it is in the pouch of Douglas or elsewhere in the peritoneal cavity, it will be peritoneal endometriosis. But most commonly, we will be learning all the manifestation with the pouch of Douglas only. Now here, every month when the endometrium has come in the pouch of Douglas, now every month it was going the changes and changes and changes, hormonal changes, and there was chronic inflammation, fibrosis, and adhesions and distortion of the anatomy due to adhesions, due to the continuous endometrium shedding which was occurring at the ectopic endometrial sites. Okay, now you tell me, if the peritoneal cavity is full of adhesions, what you will find on the PV? On the PV, of course, you will find the tender POD, and you will find the nodules because fibrosis has occurred. Uterus will be here. Again, I would like to tell you that uterus will be of normal size and non-tender. Okay, and but the uterus will be fixed and retroverted. Okay, uterus will be fixed and retroverted. Can you see all these adhesions, all these nodules on ultrasound? We can see some nodules on ultrasound which are quite big, but we can't see adhesions. We can't see distortion of the pelvic anatomy on the ultrasound. Okay, so what we do when a patient of endometriosis, peritoneal endometriosis comes to us, we just do the examination, we take the history. So what complaint will this patient give? Because there is lot of distortion of the anatomy, of course, and there is lot of inflammation in the peritoneal cavity. Now this patient will have a secondary dysmenorrhea, and the patient will have a chronic pelvic pain also, because the inflammation is going there chronically. Okay, and there will be dyspareunia also. Dyspareunia is found whenever the peritoneum or pouch of Douglas is involved. The another diseases in which there is dyspareunia is PID. There again there are peritoneal adhesions. Okay, there again there are peritoneal adhesions because the anatomy has been totally distorted, and there when the ovulation will occur, the fallopian tube is somewhere else. The whole anatomy has been distorted. It will not catch up. Moreover, the ovarian endometrioma and peritoneal endometriosis, the two can coexist also, right? So there will be infertility. If the endometrium is affecting bowel and bladder, then there can be bowel and bladder symptoms also. Now, what is the treatment of the pain? Basically, we will be doing the treatment as per symptoms. Okay, so what is the treatment of the pain? So if the patient is coming to us with endometriosis, the treatment is of course NSAIDs. It's, we have made the presumptive diagnosis on the clinical examination. Okay, and we see on the ultrasound, we see the bilateral uterosacral nodules. What is the first line treatment we give? We give the low NSAIDs and low dose. Low dose means estrogen content is low in which OCP, and continuous. What is the regime of OCPs we give usually? We give 21 days, 7 days off, 21 days, 7 days off. But here we will give continuous, because when we give 7 days off, there is bleeding, and whenever there will be endometrial shedding, there will be lot of problems, right? We have discussed it in pathology. So this time we will not let the endometrium to shed, and we will give the continuous OCPs, and that will be of low dose also. And if this doesn't get, patient doesn't get okay with NSAIDs and low dose OCPs, the second line management is continuous progesterone. Okay, either it can be formed in the Mirena or the injection depot medroxyprogesterone acetate, but it has to be given, progesterone has to be given continuous again, right? And if it doesn't, patient doesn't get okay with that also, then we will shut the HPO-axis with GnRH continuous analog or GnRH antagonist. Because when we give the GnRH continuous analog and GnRH antagonist, no GnRH will be produced from the hypothalamus, no pituitary stimulation, and then no ovary stimulation will be there, right? And no estrogen production, so no proliferation, no endometrium shedding will be there. So in total, whatever we want no endometrium shedding. We want is no endometrium shedding, because we don't want no endometrium shedding. So in all the treatments, usually either the patient doesn't have periods, because like when we are giving GnRH and we will not, the patient will not have periods, or there will be periods will get decreased. Okay, and then there are some other drugs which can also be given as a last resort, but the three lines are only this. Number one was NSAIDs and low dose, number two was continuous progesterone, and number three was GnRH continuous analog or GnRH and TAGs. Okay, now you tell me what other can we give? Okay, other drugs we can give is anti-GnRH. What is the anti-GnRH drugs? Danazol and gastrinone. They have the anti-GnRH effect, and they are very cheap. If the patient is not affordable to these regime, is not compliant to follow this regime, so then we can give this. Okay, but the side effect of danazol is that there is hirsutism in the patient. Okay, letrozole is an aromatase inhibitor. So okay, letrozole is the aromatase inhibitor. Again, there will be a hypoestrogenic stage. Mifepristone and unipristol are the anti-progesterone. So what are the other regime? First is these two, danazol and gastrinone are the anti-GnRH. Letrozole is the anti-estrogen, and mifepristone and unipristol are the anti-progesterone. Okay. Now, if the patient doesn't get okay with these treatment, then we will go for, of course, for the pain, we will go for the surgical treatment. And now we would like to go for the laparoscopy. And this laparoscopy will also help us in diagnosis, assessing the stage. So there are basically 4 stages: minimal, mild, moderate, severe, depending on the severity. And then we can also treat. What treatment we give for the, what surgery we do for the endometriosis patient? Of course, if it is a cyst, we do cystectomy, as already discussed. Chocolate cyst, for the chocolate cyst, one cystectomy. And for the other one, we will destroy the ectopic endometrium, adhesiolysis, cystectomy. These all are the things which we can do. The ectopic endometrium site, we will destroy it. We will do the cautery. We will do the laser ablation. We will do the adhesiolysis. We can do the cystectomy. We can also do the LUNA. What is LUNA? LUNA is laser uterosacral nerve ablation. Okay. Now, because it will reoccur. So after doing this surgery, we have to give that patient GnRH analog or interlock till conceiving, because it will do reoccur. Okay. And what is the treatment for infertility? As I told you, the patient for chocolate cyst will also follow the same. Okay. If it is minimal or mild severity, then we will give clomiphene citrate and IUI for 3 cycles. And if it doesn't get okay, patient doesn't conceive with this, then we will of course give IVF. Okay. And if it is moderate or severe degree or it is chocolate cyst, then we will straightway go for the IVF. Okay. What do you mean by the severe degree? Severity, it means there is adhesions, it means there is fibrosis, and there is distortion of the anatomy. Okay. So what is the basically the first investigation? So first investigation which we do is always the ultrasound. Why the ultrasound is the first investigation? To rule out other pain pathologies. To rule out other pain pathologies. Okay. And but what is the investigation of choice? The investigation of choice is laparoscopy, and if the gold standard is of course histopath, when the histopath will confirm that there was endometriotic glands and endometriotic trauma in that tissue which we were thinking of endometrial glands. Okay. So investigation of choice for endometriosis is always laparoscopy, but for the ovarian endometrioma, it was ultrasound. Very beautiful ground glass appearances there. Okay. Just one liners, because sometimes we read the whole chapter and then we get the question from the one liners. These are the newer things and the factual things both. Okay. Ectopic endometrium, it has its own aromatase enzyme. The ectopic endometrium, it has its own aromatase enzyme which is leading to the production of estradiol over there. Okay. And already there was increased estrogenicity, and here there is increased production of estrogen also there. So this will increase the severity of the diseases. Okay. The pain severity and the diseases severity, it depends on the depth of the lesion. How deep are the lesions? Okay. The pain is directly related to inflammation. More is the pain is because of inflammation and because of the neuromodulation. What is neuromodulation? That the estrogen has increased the sensitivity for the pain, increase the neural sensitivity for the pain. Okay. Endometrioma cystectomy is done to prevent the recurrence. Incision and drainage. If you are doing incision and drainage or aspiration, it will lead to recurrence. No routine removal of endometrioma is essential for the IVF. So that's all for the endometriosis. All the images are in the Telegram channel and on the WhatsApp group. So you can message me at this number in case you need any help in Obscene Gynae for FNG, INASET and NEET PG exam. I will give you the link of the WhatsApp group and the Telegram group where daily quizzes are conducted. Okay. And that was all for endometriosis. If you have any problem, please write in the comment section. Keep watching the videos. Lots and lots of concise, conceptual videos will be coming, which will surely improve your obs-gynae concept. I hope you like the videos. Do comment and share it. Thank you.